Welcome to the first special session of the Epidemiology Internship Training Program. Today we're going to talk about disease frequencies and measures in epidemiology. As we go through the course, as more difficult concepts come up, we're going to have special sessions so that we can dive into these concepts more and make sure that everybody's on the same page. So broad measures are used in epidemiology. We have counts, proportions, ratios, and rates. It's really important that you understand how the disease frequency measures that we discuss fit into what they are. So sometimes epidemiologists just simply count cases, but more often we talk in terms of ratios. We look at proportions and we look at rates. I'm going to talk a little bit about prevalence and incidence, which are two measures that are very important in the world of epidemiology. From there, we're going to also dive deeper into crude, specific, and adjusted rates because sometimes those concepts are kind of difficult to understand if it's your first time learning. So prevalence, what is prevalence? It's the number of existing cases of a disease or health condition in a population at some designated time. So basically, prevalence is just simply a proportion. This proportion is really important because you can look at it as part of a whole. You have part of the population who has this disease or health condition over the total population, and that's a really important measure. Some different uses of prevalence include describing the burden of a health problem in a population. So if they wanted to talk about, okay, well, how many people have myocardial infarctions each year in a designated population, then you would use the term prevalence. Also, it's not just a proportion of people who have a disease or a health condition in the population. Prevalence is also used to estimate the frequency of exposure. So if you say, okay, well, what proportion of the population smoke, then you can say the prevalence of smoking in the total population. So it can be a proportion of those who are exposed. So it doesn't necessarily have to be a disease outcome. And then finally, prevalence is used often in determining allocation of health resources, such as facilities or personnel. When healthcare administrators are trying to determine workload, then they use prevalence measures in order to plan what needs are happening in the community. So just to show you the formula, and this is not a formula that you should memorize because ultimately once you understand the definition, then the formula comes with it. So point prevalence, just the number of persons ill over the total number in the group. So obviously the reason why this is a proportion is because the numerator numbers are also found in the denominator. So an example, total number of smokers in the group, however that group may be defined, over the total number in the group. Now you have point prevalence, but you also have period prevalence. The definition is very similar, except in period prevalence is just during a specific time period. So number of persons ill over an average population. Now sometimes this average population is just taken at the midpoint so that you can have an estimate of population numbers that change, so you just take the average from the beginning to the end. There's different ways that this is done, but really this is, again, just looking at the number of existing cases during a time period rather than just simple cross-section period of time. So cumulative incidence. Now cumulative incidence is really important because basically when somebody talks about cumulative incidence, they're really talking about risk. So if you ever hear somebody saying the word risk and prevalence in the same period, they are completely misusing this word. So if somebody wants to talk about risk, then cumulative incidence is going to be the measure that is used. So the definition of cumulative incidence is the proportion of people who have become diseased during a specified period of time. Now period is very important because unlike prevalence that has both a point prevalence and a period prevalence, cumulative incidence always indicates a period of time. This period of time is called the risk period. Cumulative incidence is a proportion as well because the numerator is a part of the denominator. So the way that you calculate cumulative incidence is the number of new cases, not existing cases, but the number of new cases of disease during a time period. and the denominator is the number of disease-free people at the beginning of the time period. Now that is also very different from the denominator in the prevalence. So with incidence, you start off with disease-free people, and if the whole idea is to calculate a measure that talks about the risk of somebody developing a disease, then you need to start off your population at the beginning of the time period only with those who are at risk for the disease. Okay, and so depending on what type of health condition you may be looking at, it may be disease-free people, and you have to define that based upon the example. Now, some applications of incidence data. Now, with prevalence, when you're looking at prevalence, you're looking at workload, you're looking at burden on the population. With incidence data, because you have that risk period, because you have that follow-up period where you're following people to see if they develop the disease, incidence data is really used in looking at the etiology or the causality of a disease, meaning looking at it from the time somebody is first exposed to the time when they actually develop the disease, or maybe from the time somebody picks up their first cigarette to the time that they develop lung cancer. And so etiology is just saying the causes of the disease. And so because you have that time component with incidence data, then you can study etiology and causality of a disease or a health condition. You cannot do that with prevalence data because you don't have that follow-up period. Now, again, anytime anybody talks about the risk of developing a disease, they are talking about some sort of incidence measure. If you hear anybody talking about risk and they're giving prevalence measures, they are misusing the word, and that's a really key component in epidemiology. Additionally, you can use incidence data in order to estimate the effects of exposure to a hypothesized factor of interest. So when you're wanting to look at cause and effect relationships, then you want, and this is very similar to the first point, you want to start off with disease-free people and you want to see who develops it and who doesn't, and then look at exposures. So if you want to look at an exposure-disease relationship, and you may think that this exposure causes this outcome, then you'll want to use incidence data in order to do that. Now here's the problem. Two conditions actually need to be satisfied in order to calculate cumulative incidence, okay? Remember, cumulative incidence is a proportion, okay? The first condition is that you need to have a fixed cohort. What that means is that no new members are allowed in the study population after the start of the study. Now, in a fixed cohort, you may lose existing members during follow-up due to what we call attrition. Now, different reasons is loss to follow-up, voluntary withdrawal, or deaths from causes other than the case under study, or other than the cause under study. You may lose people, but ultimately the first condition is a fixed cohort. So once you decide that you want to start the study on January 1st, you cannot add any more people. However, the second condition now becomes perfect follow-up, which says, you know, in a fixed cohort you can have attrition, but the second condition is, oh, actually you can't have any attrition in the study. Okay, so that means if somebody started in your study in January 1st and you close your study December 31st, in order for you to calculate cumulative incidence, you must have everybody following up in that study. Now, once you put these two conditions together, saying that you start with 100 subjects, you must end with the same 100. It just simply means you didn't gain or lose any specific members, okay? Now, obviously, attrition can happen because of different reasons. People may not just return your phone calls when you're trying to follow up with them. People may not show up at the clinic. People may move away from the study catchment area. There's so many different reasons, and the longer you conduct the study, the higher the likelihood that attrition is going to affect your study population. And so here's the problem with attrition. When people leave the study for whatever reason, you ultimately don't know whether or not they developed the disease. And so you can't say they didn't develop it, and you can't say they did develop it basically you can't say anything. And so what ends up happening is you have to drop them from your data analysis. But that can also introduce bias into the study. And so ultimately we need to come up with some measure that estimates risk even when we can't calculate cumulative incidence. So remember, cumulative incidence, in order to calculate that proportion that directly estimates the risk of developing a disease, you have to meet these two conditions. But in reality, we don't always meet these two conditions. So when these two conditions are not met, then you can no longer calculate cumulative incidence, that proportion. Instead, you have to calculate incidence density. Now, incidence density is what we call a rate, okay? A rate means that you have a numerator and a denominator, but that time plays an intrinsic role in the denominator. So when those two conditions are not met, you need to actually take into account time in the study, okay? Now, in reality, we have dynamic populations. Unless you have a very tight time period, more likely than not, you're going to be calculating incidence rates, incidence densities, because of a dynamic population, because of a dynamic study population. So think about some cohort studies that have lasted for 30 or 40 years. Cumulative incidence is out the window because the study has lasted so long, and so incidence rates, or more specifically incidence density, needs to be calculated. However, in situations where you may have a very short time period, such as in an outbreak scenario, a foodborne outbreak scenario that says, okay, this group of people went to this picnic. We know who's there. We can ask them about who went, who was feeling fine, who ended up getting disease, salmonella poisoning. Then we can calculate cumulative incidence because we are accounting for everybody in the study. So when we're talking about incidence density as a form of a rate, what we do is, instead of counting individual people who are disease-free in the denominator, what we end up doing is we count disease-free time units. It's the amount of time that those study subjects actually contribute to the study when they're disease-free. Okay, so sometimes you'll hear this called person time. Now, an incidence measure is used when members of a population or study group are under observations for different lengths of time. So in reality, even though we may start a study on January 1st, we may still be recruiting people into our study on February 1st, okay? So we may want to add people. Sometimes people will move away and they can't participate in our study. Well, we still want to keep the data that they contributed up until the point that they moved. So again, all these different reasons as to why somebody may join the study late, why somebody may leave the study early, we still want to get as much data and use as much data that they contributed, even though it was during different periods of time. So the way that we calculate incidence density, it's very similar to cumulative incidence, except it's not a proportion, it's a rate. But the numerator is the exact same. So it's the number of new cases of disease during a given time period. Okay, so the numerator in cumulative incidence and in incidence density is the exact same. The only difference is the way the denominator is defined. So the denominator in incidence density is the summation of each person's time under observation and who were also disease-free, which means once they develop the disease under study in the population, they no longer contribute disease-free time units. Now here's the notation. Don't get scared with the math formulas, but basically what that is looking at is from time period A to time period B, how many new cases were there and how many disease-free time units were contributed between point A and point B. So another definition is just the average rate of development of disease in a population. Now here's the thing, when you look at the bounds of this number, incidence density rate can run from 0 to infinity, whereas proportions run from 0 to 1, okay? So for example, 80% as a percentage or a proportion is 0.8, right? So prevalence and cumulative incidence are proportions, and they run from 0 to 1, okay, so from the upper to lower bounds, but incidence density rate can go from 0 to infinity. So let's look at an example. We have a hypothetical group of persons who were followed for 5 years for a hypothetical disease. So these were 5 people who were followed during varying amounts of time. So you can see somebody joined the study in January of 1976, others joined the study in January of 77 and 78. And then ultimately the study shut down January of 1981, but people contributed different amounts of time. So person A was in the study for 2 years, from January 76 to January 78, but they were at a loss to follow up. We couldn't contact them anymore, and so they actually only contributed 2 years rather than running until January of 81. Person B actually started the study in July of 1976 and developed the disease understudy in July of 79. So even though we were following them, even though they were still a part of our study, they stopped contributing disease-free time units in January of 79. And so you can go through each person. And so ultimately, we need to calculate the incidence density rate, okay? And so what that would be is the number of new cases of disease, so going down to what is the incidence density. The number of new cases of disease in this particular population is 2 cases because person B and person E developed the disease. Then the denominator is the number of disease-free time units, and basically we calculated it in terms of years. So person A contributed 2 years to the study. Person B contributed 3 years of disease-free time to the study. Person C contributed 5 full years, so the 5-year study, 5 full years to the study, and so on and so forth. So what that ends up calculating out to is 0.12 cases per person year. Now, we need something meaningful, okay? And saying, well, there's only 0.12 cases per person year may not be meaningful in, say, the case of a chronic disease. So, you know, we do conversions a lot in epidemiology in order to standardize and in order to make certain measures meaningful. And so if you move your decimals, ultimately what you see is for every 100 person years contributed to the study, and that may be 1 person for 100 years or 2 people for 50 years, then ultimately we would expect 12 cases, okay? So this would be 12 cases per 100 person years. Now, this is what I'm saying, and you have to be really careful in how you interpret it, okay? Because ultimately, disease-free time units can be defined in different ways. It could be person days, it could be person months, it could be man hours, and you have to be really careful in how you interpret those denominators, because 16 person years could mean 16 people were followed for 1 year, and 8 persons were followed for 2 years, or 32 persons were only followed for a half a year. So you have to be really careful in making assumptions. So man hours, if you're into architecture and engineering, man hours is often used to describe the construction of buildings. So when you say, okay, well, how many man hours went into the discussion or the construction of the Empire State Building, then ultimately it would be millions, probably hundreds of thousands. But when you look at man hours that go into just the building of a simple residential home, then it's going to be a lot less. So looking at how that can describe the population is really important when trying to look at interpretation. So formulas for incidence density, it really just depends on how you define things. And so we've talked about definitions in epidemiology are really, really key. So incidence density, number of new cases during the time period over total person time of observation. So if the period of observation is measured in years, then the denominator becomes total person years of observation, but the denominator again could be total person months, if you're talking about an acute onset of a disease, or it could be man hours when talking about the construction of a building, for example. So looking at another example, ultimately you would be presented with columns A and columns B, and you would say, okay, well, I need to calculate incidence density from this example. You're also given that the number of health events, in this case heart attacks, observed during the 10-year period was 5, so you already have your numerator. So how do you calculate your denominator? Well, you would just take A times B. So for the first line, there's 30 subjects that contributed 10 person years, and so ultimately that's 300. You do that for every amount of time, every length of observation that was contributed, and so the incidence density formula would end up being 5 over 461. Ultimately, to make that meaningful, some people look at it in terms of 100 person years of observation, and so for every 100 person years of observation, we would expect one case to occur. So it's really important that you understand the difference between prevalence and incidence, and that you really understand in what situations they can be applied. So again, prevalence, the definition is it refers to existing cases during a period or point in time, depending on how it's defined, and it's used to describe the health status of a community in terms of exposure or outcome, or the planning of health services. Incidence refers to new cases of disease always developing over a period of time. If you want to talk about risk directly, then you're going to use cumulative incidence. If you want to indirectly estimate risk, you still are going to calculate an incidence measure, but in this case it's going to be incidence density. So incidence density, again, is used when you have subjects coming late into the study or subjects leaving early, which frequently happens, and that's an indirect estimate of risk. Now, incidence measures, whether cumulative incidence or incidence density, they are really helpful for research when looking at etiology, causality, prevention, and treatment of disease. But you have to have that follow-up time. Now, there's actually a relationship between prevalence and incidence. The formula is prevalence equals I times D. Prevalence equals incidence times duration of disease. Now, ultimately, the duration of the disease is defined based upon a clinical endpoint, okay? In some cases, the clinical endpoint may be recovery from the disease. So, for example, the common cold. We expect the vast majority of people to recover from the common cold. So the duration of that disease is duration of disease onset to recovery. However, in fatal cases, let's say in people who have a comorbid condition of tuberculosis and HIV, that's a very lethal combination. And so actually the clinical endpoint is not recovery. The clinical endpoint is death due to the disease or comorbidity. And so the duration of the disease in this point is defined as time until death. So it's very important that you understand that that's very health condition specific. So if you want to try to calculate, let's say, incidence when you only have prevalence and duration of the disease, then this formula is going to help you do that. If you want to estimate prevalence and you only have incidence and duration measures, then you can plug numbers into the formula. You just have to make sure the units are the same. Now, this is frequently called the epidemiologist bathtub. One way to look at it is that you have new cases. So you have a bathtub, you have a faucet where water's coming out, and what that represents is new cases of disease defined as incidence. The water level is defined as prevalence because the new cases are flowing into this body of existing cases, and the drain or the outflow is recovery or death. So looking at it this way, the water level, again, is the whole body of people who are existing cases. And deaths can either go out the drain or splash out the top, deaths, the duration can either be deaths or recovery, and so deaths would be down the drain, or recovery could be splashes out the top. But ultimately, you can understand that the relationship that as new cases come flooding into the bathtub, depending on what the duration of disease look like, ultimately prevalence can be increasing. And so it's really important that you understand this relationship when looking at a health condition of interest. So ultimately, water level depends on inflow and outflow. And so prevalence depends on inflow and outflow. Prevalence depends on incidence and the time it takes to recover or die in the case of a fatal disease. So think about the relationship this way. If a duration of disease is very short, okay, meaning people die rapidly or they recover rapidly, and the incidence is very high, then prevalence and incidence starts to be the same, meaning the water in the bathtub and the amount of water coming through the faucet tends to be roughly equal, okay? A common example would be the common cold. So you've got people recovering frequently, you get people getting the disease frequently. So the duration is small, and so the number of new cases and the number of existing cases tend to equal out. However, if the duration of the disease is very long, okay, so that means the time spent as water in the bathtub is very long, and the incidence is low, so the water is just dropping at a very low rate, then ultimately what happens is the prevalence starts to increase in numbers relative to the incidence. And what ultimately ends up happening, you have a ton of existing cases, and it's just a slow drip with incidence, okay? And that's really what happens with many chronic diseases. So as people start to live longer, we have just a spike in prevalence because we're actually able to keep them living longer, even though they may not fully recover, but we still have a steady trickle of cases. A great example is looking at HIV. If you were to solely look at HIV prevalence, which is the blue line here, you would see the number absolutely skyrocket. And people, if you just look at prevalence, they would say, wow, HIV is just, despite all of our intervention, despite all of our programs, HIV prevalence is just skyrocketing. What are we doing wrong? Well, actually, we're not doing anything wrong. What this is saying is based upon basic science research, based upon public health research, people are just living longer with the disease. And so because we can't cure it, the graph that we see here is that the number of existing cases, yes, are growing up because there's always a steady trickle of cases. But this is really great news because what that means is that people are living longer with the disease. And so in reality, in order to get a good picture of really what's happening with HIV, you want to look at prevalence and incidence together. And so here you can see the incidence rates of HIV as we learned more about the disease, as we defined it better, they actually increased, but now they are in decline and kind of hit a steady state at this point. So it's really important that in order to get a global picture of a health condition, that you look at disease duration, that you look at prevalence, and that you look at incidence. Because if you only take one measure, then it's not going to give you the big picture. So there are different applications of incidence data, and this is really what I wanted to talk to you about because there are a lot of rates used in epidemiology. We have crude rates, we have specific rates, and we have adjusted rates. There's no need for you to go and memorize rates, but it is important for you to understand what these rates mean, how they're calculated, and what the limitations of them are, so that you, when faced with certain scenarios out in the population, that you know exactly what rates to calculate in order to give you what you want, in order to understand disease distribution. So crude rates are just simply summary rates based on the actual number of events in a population over a given time period. For example, crude death rate. So all that means is how many people die in the total population. It's just a very crude rate. So if we were to talk about crude birth rate, how many people were born over a total population. There's also something called specific rates. Specific rates are rates that look at like a specific or a particular subgroup of the population. Now, this subgroup of the population can be defined in totally different ways. It could be, okay, well, we're going to look at this racial or ethnic group, we're going to look at this age group, or it may be we look at cause-specific rates, meaning how many people have HIV. Okay, so that's just a very specific, well-defined subgroup of the population, okay? And a good example would be a cause-specific rate. But then there are adjusted rates. And if you spend any time in the public health literature, on CDC's website, you know that adjusted rates are used a lot. But have you ever thought about, well, what are adjusted rates? What does that actually mean? Well, adjusted rates are just summary measures of the rates of morbidity, sickness, and mortality, death, in a population in which a statistical procedure has been applied in order to remove the effects of differences in populations with various compositions, okay? And we'll talk more about each one of these. So, measures of natality. The Friss book really goes into and spends a lot of time talking about crude measures that are used when talking about birth, pregnancy, maternal rates. It's really important that you know these measures, that you don't memorize them, but they're often used even when we're not talking specifically about birth or pregnancy matters. These rates are actually used often to describe the health status of populations, to describe the health status of countries. So if we wanted to look at comparing health access, health services, come up with some score in order to say, okay, well, what country has a healthier population than another country? Then actually these measures are frequently used in order to describe the health status of a population, simply because when you look at babies being born, babies living past a certain time period, mothers being able to have healthy babies, mothers being able to get through childbirth. These are measures that are indicative of a much greater issue, which is, do you have good health services? So I think that's really why Friss goes into so much time and effort to talk about these rates, and so I just wanted to briefly mention them as well. So looking at the crude birth rate. So this is a crude measure, okay? Crude birth rate is often used when looking at population dynamics. If you wanted to project population changes, then you would use the crude birth rate. So again, it may not be a researcher that's simply looking at birthing practices or birth rates because that's their subset. You have a lot of people who study population dynamics that look at population changes. People in the government, if they wanted to look at, say, burden on Social Security, would obviously look at crude birth rate. It's ultimately affected by the number and age composition of women of childbearing age. Now, again, it's really important that even though we talk about crude birth rate, that you always define what that means, because even though there is an accepted way to define it, you always want to be very clear what your numerator and your denominator is. So in this case, we're going to define crude birth rate as the number of live births within a given period, let's say during a particular population, over the population size at the middle of that period. So, even though this looks like a proportion, we call it a rate because it's looking at the average population size, and the way that we do that is by taking the middle of the time period. So, for example, if our time period was January 2016 to December 2016, then we may look at the population size at July in order to kind of estimate that average. Okay, so a sample calculation. 4.1 million babies were born in the U.S. during 1991 when the population size was 252 million. The birth rate, therefore, was 16 per 1,000. So for every 1,000 people in the population, ultimately there were 16 live births. And so you can actually look at that to project population change. General fertility rate. Again, it's very important that we define the numerator and denominator. The general fertility rate is actually used in order to compare fertility rates between age groups, between racial groups, between socioeconomic groups, in order to really understand, okay, who are reproducing, what does that look like in terms of population makeup in the future. So a general fertility rate would be looking at the number of live births within a year over the number of women who were in childbearing age, okay? And so in this case, it's defined as between 15 and 44 years, okay, during the midpoint. And so, for example, this would be a great test question is, can you tell me the difference between general fertility rate and crude birth rate? So it's really important. So even though they share numerators, the thing that makes it different is the denominator, because it really tells you something different, right? So the general fertility rate, the denominator is defined as women of childbearing age, okay, which we've defined here as 15 to 44 years. So it's really important that you define what you mean when you're looking at these formulas. So for total fertility rate, this rate is the average number of children that would be born if all women lived to the end of their childbearing years and bore children according to given set of age-specific fertility rates, okay? In this case, the total fertility rate is 2.06. Here in the United States in 2012, we say that the replacement rate, in order to keep a population steady, is about 2.1. And so if you wanted to look at it from a population dynamics standpoint, if we are not meeting our replacement rate, then ultimately what may happen in the future is population is shrinking. In fact, many Western European countries actually have a total fertility rate lower than the replacement fertility rate, and so their population is shrinking. But when you look at these countries where the total fertility rate is extremely high, and especially in developing countries where people have more than 2 kids, then ultimately you know to anticipate a population boom in the future. So let's look at fertility rates in the United States from 1950 to 1992. So I just said population boom. You probably heard the term baby boomers. Well, those are people who were born between this 1950 and 1960 time point. And you can see that it really was like a huge boom of births in the population of women who were in a certain childbearing age. And then ultimately that has decreased. People are waiting later in life. People are having less kids. When we were really in an agrarian society, especially like farming families, they would have several kids in order to support the farm, but obviously with increase in urbanization, that's not needed. Now this is looking at the overall fertility rate, but you could also examine fertility rates in specific age groups, fertility rates in specific racial groups, in specific socioeconomic groups. So it's really an enlightening statistic. So fetal death rate. Fetal death rate is frequently used to estimate the risk of death of the fetus associated with stages of gestation. Okay, so the way that you define fetal death rate overall is looking at the number of fetal deaths after 20 weeks or more gestation over the total number of live births and number of fetal deaths. Okay, so that's a total population definition. If you wanted to look at late fetal death rate, then you may look at that late time period is number of fetal deaths after 28 weeks or more of gestation over a similar population. So what does this tell you? Well, we know that miscarriage rates are very high in the beginning of pregnancy, but then they start to taper off. And so if you have a spike in fetal death rates in a population, that's really alarming, because after that kind of 20 weeks of gestation, then you're kind of dealing with an entirely different ball game, right? And so this is a measure looking at, okay, well, maybe there was environmental exposures that we need to examine further, because having high rates of miscarriage after 20 20 weeks should be rare at that point. So fetal death ratio refers to the number of fetal deaths after gestation of 20 weeks or more divided by the number of live births during a year. So it's very important that you tease out the differences. So in this case, just looking at the number of live births in the denominator. Now, the infant mortality rate, again, people who don't even look at research into infant mortality use infant mortality rate in order to compare countries. So it's frequently used for international comparisons. A high infant mortality rate indicates unmet health needs and poor environmental conditions. So if a child makes it through childbirth, which is a very traumatic experience, then basically after childbirth, the time from day 0 to 365 days is a very important time as well. And so when you're looking at malnutrition, when you're looking at rates of breastfeeding in international settings, when you're looking at infectious diseases, then people look at infant mortality as kind of a proxy of describing the health status of a population. So infant mortality is defined as the number of infant deaths among infants aged 0 to 365 days, so to the first year during the year, over the number of live births during the year. Now, one thing that I do want to point out is, so sometimes you see per 1,000 live births. In some scenarios, depending on how you define the population, it may be defined per 100,000. Some journals actually say, okay, well, if you're going to present this rate, then present it in using these numbers like per 1,000. Some may say, okay, well, I prefer to see it in per 100,000. Well, those are just decimal conversions, okay, in order to make it meaningful to your audience. So Frisk tends to say, okay, well, when you're calculating infant mortality, then go ahead and put it per 1,000. But if, say, you were doing like large international comparisons, 100,000 live births may be more meaningful. It just depends. So looking at infant mortality rates by race in the United States, looking at 1950 to 1995, you can see that even, again, if you're not studying infant mortality specifically, you can look at this chart and say, wow, look at these health disparities. So maybe you're a health disparity researcher. So this chart is glaring when you look at the average of all races, but then you start to tease it out by race of the mother, and you can see that Caucasian actually have lower, below average, and African Americans have higher than average rates. And so that gap between Caucasian and African Americans is actually, I mean, that is what we would call a disparities gap. And so again, you can use this if, say, you're looking at disparity research, then you may use this infant mortality rate in order to highlight disparities in a population. So neonatal mortality rate, this just reflects events happening after birth. Primarily, we look at congenital malformations, prematurity, and low birth rate. Okay, so if you have people, if you have babies that are dying very soon after birth, that can be indicative of congenital malformation. It can be indicative that you're having babies that are born before they reach full gestation at 38 or 40 weeks. Or it could mean that, you know, you have a spike in low birth weight babies, which may be, let's say, indicative of increased substance abuse rates in the population. So neonatal mortality rate is the number of infant deaths under 28 days of age for the infant over the number of live births. Now, this is really important in comparing neonatal to post-neonatal mortality rate, because ultimately the reasons on average why infants die in situations less than 4 weeks old and in situations greater than 4 weeks old, they're very different, okay? So if a child dies from the time that they're born and up into a month, the reasons why that child dies is going to be very different than the reasons why they die after being alive for a month. Okay, so for example, if a child dies like 4 or 5 months old, then that could be indicative of infectious diseases, malnutrition, and different reasons than having survived childbirth, right? And so it's really important to tease it out. So you look at neonatal mortality rate and postneonatal mortality rate. Now, neonatal and postneonatal come together to define the infant mortality rate. Okay, so you can see the overall infant mortality rate, and then ultimately you can see it kind of divided out between neonatal and postneonatal. So based upon this, looking at these rates in the United States, you can see infant mortality rate is high, okay, but it has been in a steady decline from the 1960s. And that ultimately, in this country, the most hazardous time for the babies are that first month after childbirth. So in developed countries such as the United States, they are more likely to die in that first month after childbirth because of congenital malformations, because of being born early or low birth weight, than they are during the post-neonatal period after that first month. Now, if you were to look at a developing country, for example, you may see this gap actually close between neonatal and postneonatal, because it may say, okay, well, children are dying during childbirth, but it may be closer to, okay, well, just because the child's born doesn't mean that they're going to have access to healthcare services if they were to get sick. It doesn't mean that they're going to have adequate nutrition, so they may be malnourished. So in developing countries, you may see the neonatal and postneonatal rates start to converge depending on the area. So perinatal mortality rate reflects environmental events that occur during pregnancy and after birth. So what it does is it combines mortality during prenatal and postnatal periods. Okay, so again, this may look at environmental exposures while the woman is carrying the baby, and also after birth, immediately after birth, so 7 days within birth. Maternal mortality rate is used just as frequent as infant mortality rates when trying to make international comparisons. So maternal mortality rate is used to reflect healthcare access, socioeconomic factors, because ultimately what maternal mortality rates say is, okay, can a woman go to a hospital and get treated if there were any pregnancy complications? Did she have access to healthcare services? Okay, and so if you have women who are dying due to childbirth, then that may be indicative of gaps in healthcare access, gaps in healthcare quality. Okay, and so maternal mortality rate is used frequently in healthcare economics or health economics as well. So here's the problem with crude rates. So you have to really use crude rates with caution, because they're crude rates. They're just simply a numerator over a denominator. And when you're trying to make comparisons, you have to really make sure that your comparisons are comparing apples to apples, oranges to oranges, okay? So observed differences in crude rates may be the result of systematic factors within a population rather than the fact that, okay, there is a true variation in rates. So when you're comparing populations, is it really fair to compare the United States to Uganda? Is it really fair to compare Iceland to Thailand? You have to look at age composition, you have to look at socioeconomic composition of the population. And so crude rates, while it's a really good start in comparing populations, what happens when populations start to vary, okay? And so that's when we're really going to start talking about adjusted rates. Before we talk about that, though, I do want to briefly mention specific rates. Some examples that you're going to run across in the course of this training program is you're going to look at cause-specific rates, proportional mortality ratio, and age-specific rates. So let's look at that. So a cause-specific rate is just when you are looking at the mortality of a given disease, so death due to a given disease, or you may just be looking at morbidity of a given disease, the frequency of the sickness of the disease, okay, over the population size at the midpoint of the time period, okay. And so in this case, we're times it by 100,000. It just really depends on what the accepted format is. So, for example, if we wanted to look at the cause-specific mortality rate due to HIV in 1996, here you can see that once we do the calculation, about 27 people for every 100,000 in the population ultimately died due to HIV. Now, this is different from proportional mortality ratio, and it's really important that you understand these nuances in the formulas. So proportional mortality ratio is just the mortality due to a specific cause during a time period over the mortality due to all causes during the same time period. What this does is it gives you another measure that kind of starts to highlight the relative importance of a specific cause of death. However, understand this is not a measure of the risk of dying of a particular cause, okay? So here, this is certainly a proportion, okay, and not an estimate of risk, okay? And so if I was to ask the example, what's the difference between proportional mortality ratio and the general mortality rate in the population, would you be able to tell me the difference? Okay, and so that's really important in saying, okay, I understand what this word means and I understand what this formula tries to convey. So, for example, let's say that you wanted to look at, calculate the proportional mortality ratio of the top 10 reasons of death, leading causes of death between 25 to 44-year-olds, looking at all races and both sexes. For example, you can see naturally 25 to 44-year-olds are not dying of old age, so what's the leading cause of death? Well, typically at the top of the list are accidents. So what proportion of deaths are due to accidents, okay? And so what that says is proportional mortality ratio, 17% of all deaths in the population are due to accidents, okay? So that's what the PMR tells you. Now, if you were to look at the cause-specific death rate, that is how many deaths are due to accidents and adverse effects per 100,000 in the population, that's a very different measure, and in this case it's 31.7, okay? So take some time to really tease out, okay, if I was to be asked the difference between proportional mortality ratio, cause-specific death rate, and a crude death rate, would I be able to highlight those differences? Because ultimately what happens is they all start to sound the same, but in reality, they tell you completely different numbers. This was actually a study guide that was very helpful to me when I was a public health student, because ultimately it kind of started to tease out the differences in these definitions. So maybe you could draw this in your notes and you can reference it when you are trying to say, okay, what's the difference between crude mortality rate, what's the difference between cause-specific mortality for disease, case fatality, or proportionate mortality. And really, again, the whole difference is how do you define the numerator and how do you define the denominator, and what's the relationship between the two, okay? So maybe this chart will help you as well. So looking at an age-specific rate, this is just the number of cases of whatever you may be looking at, okay? It may be morbidity, it may be mortality, per age group of the population during a specified time period. So for example, the number of deaths among those aged 5 to 14 years, and the population denominator would be number of people who are in that age group, okay? And so what that really tells you is how does death affect that age group. And so you'll see age-specific rates used often as well. In order to calculate age-specific death rates, really what you need to do is you just need to set up proportions, okay? Age-specific death rates, looking at the under 1 age group, just set up a proportion where you have, okay, well, 38,000 deaths occurred in 3.2 million people. So if I needed to get that to a proportion that represents 100,000, how many deaths does that represent? Okay, and so ultimately what you would do is 38 over 3.2 equals X over 100,000. And when you do that calculation, when you solve for X, then ultimately what you get is 1,192. And so that is the age-specific rate per 100,000 people in that particular population group, okay, which in this case is the under 1 age group, okay? So if you were to be given this example on an examination, then you would be given your group categories, the number of deaths, and the number of, in that population, in this case it's the 1990 population. Could you calculate these age-specific rates for each age group? That would be a classic testing examination question. Some other important incidence measures. We talk a lot about case fatality rate. You've already heard about attack rate, okay? You know, they should really be called case fatality risk because it really is a proportion. Attack rate should really be called attack risk. But we tend to, in epidemiology, make things a little complicated, simply because, like, for example, attack rate. When you talk about attack rate, it's typically used in order to describe the onset of a disease in a well-defined population in a short time period. And so you use it in outbreak investigation. So you have looked at attack rates in the population already. Now, case fatality rate's really important. Even though we say it is a rate, it's actually calculated as a proportion, which is the proportion of infected individuals. So all those people who are sick compared to all the people who actually died, okay? So ultimately what happens in case fatality rate is the numerator is the number of deaths due to that disease, and the denominator is the number of people who were sick because of that disease. And so, like, for example, with the Ebola outbreak that occurs in West Africa, case fatality rate is really important because with Ebola, case fatality rate, depending on what type of strain it is, depending upon environmental conditions, can be widely variable. When we talk about case fatality rate of influenza in a normal influenza season, okay, so a non-pandemic season, it may be 0.0002% of the population who actually get influenza die, even though that's actually kind of high. But when you look at the 1918 Spanish flu pandemic, then people estimate case fatality rate at about 2.5%. And so what that says is out of every 100 people who got it, then 2 people died, and that's actually really, really high for influenza. Now, if you want to look at case fatality rate with known human cases of avian influenza, when you look at the World Health Organization website with avian influenza, particularly H5N1, you can see the case fatality rate stands at about 60%. So to put that in useful terms, out of 10 people who are infected, 6 of them are going to die. So it's a very alarming number, and it can be used to really say, okay, how virulent is this disease in reality? And so we've talked about attack rate. It's just the number of affected divided by the number of exposed, and again, it's used in outbreak investigations. So finally, we talked about crude rates, we talked about specific rates, so now let's talk about adjusted rates. Adjusted rates is kind of a difficult concept. When you hear the word standardization, you know that this means when you standardize something that these rates have been adjusted based upon some factor, okay? And the thing is adjusted rates, even though it's kind of a difficult concept, it tends to be a better indicator of the differences between populations in risk of disease than crude rates. Because again, when you're using crude rates to compare populations that vary in composition, then it's not really useful. Okay, so you adjust based upon those variables that they do vary with in order to get a better picture of how they actually compare. So there's two methods of standardization that the book talks about: indirect and direct methods, okay? And it's really important that you understand the differences between direct standardization and indirect standardization. And the primary difference is that it really refers to what death rates you use, okay? So who was the source of the rates? So let's talk about that further. So standardizing is just a blanket term used to describe techniques to remove the effects of age or other confounding variables when comparing two or more populations that vary in composition. So direct standardizing is when specific rates in a study population are averaged using weights from a standard population. Okay, we do direct standardization when our study population, the age structure is known and the mortality rate is known. Okay, direct standardization is the most useful, effective form of standardization because you're actually using the rate from the population of interest. Okay. And so ultimately, if you don't have that, if it's unavailable, if it's unstable, then what you do is you move to indirect standardizing. And what ends up happening is instead of using the rates, the mortality rates from the population that you're trying to study, you instead use death rates from a standard population. Okay, and so you can see why that would be less desirable because you have this population of interest, but the death rates that you use to study the population is coming from a standard population instead. Okay, and so if you were to ever calculate a standardized mortality ratio, that should indicate to you that you're doing indirect standardization method. Okay. The standardized mortality ratio is simply calculated by dividing the observed crude rate by the expected rate and multiplying by 100. So let's go into a little bit more detail. So when you're calculating age-adjusted rates in this class, what that means is that you're removing the effects of age in a population, okay? Populations can vary based upon age structures, okay? And what you need is an age-adjusted rate to show a single summary measure for an entire group or population, okay? And so if you were to go to the CDC's website and look at age and burden of disease on a population, they will more likely than not present age-adjusted rates to you because ultimately age has such a profound effect on morbidity and mortality rates. For example, if you were to look at cancer rates in a population, if a population was to have a large number of older people, then it would look like those cancer rates are really high, right? Because who are the people who typically develop cancer? It's older people, okay? And so it's really important to get a good idea of, okay, well, how does cancer affect this population, that ultimately you try to remove the effects of age in order to really, truly see the impact of cancer, okay? So why standardize? So let me give you a really good example. The national average cancer mortality is about 183 people die each year of cancer per 100,000 residents. Okay, so that's in the entire United States. So for every 100,000 residents, you have 183 people who die due to cancer. However, when you start to break down cancer mortality rates by state, something very interesting happens. You find that in Florida, 239 people per 100,000 residents per year die due to cancer. In Alaska, that number is 73 residents die due to cancer per 100,000 people. Those are crude rates, okay? What this tells you, if you were to just look at these crude rates, it would say, oh, okay, wow, something in Florida is causing cancer. If you want to avoid or lessen your risk of dying from cancer, do not move to Florida. Instead, if you want to kind of find the fountain of youth, then maybe move to Alaska because your risk of dying from cancer is a lot lower. But what happens? Well, basically, you know that a lot of people, when they go to retire, move to Florida. And so actually, is it really appropriate to compare cancer rates, cancer death rates in Florida to an Alaska population, because ultimately the age structure of the population in Florida is a lot older on average than in Alaska. So what we need to do is we need to remove the effects of age from the Florida population, from the Alaska population, so that we can really compare the two, okay? So that we can say, okay, instead of comparing apples to oranges, an older population to a younger population, let's remove the effect of age in order to really compare apples to apples. And so the median age in Florida is roughly 32 years old, but the median age in Alaska is 22. So ultimately what that is saying is geographic differences in risk are what we say confounded by age. Now, confounded is a really important word in epidemiology. Confounded just means you have some sort of variable that affects the exposure-disease relationship, okay? So that third variable, in this case age, really affects the relationship between geographic location and cancer deaths, okay? In order to be a confounder, the variable, which in this case must have a different distribution in the population being compared, okay? It must be a risk factor for disease, so of course, age is certainly a risk factor for cancer deaths, and it must not be on the causal pathway, okay? What does that mean? Going back to look at this, geographic location must not cause age, and then age cause cancer deaths, okay? If that's the case, it's not a confounder, and we're going to dive deeper into that throughout the epi training program. So there are different ways to handle confounding. Now you can match, so for every 80-year-old in my study, I'm going to have so for every 80-year-old in Florida, I'm going to have a 80-year-old Alaskan in my study. You can also restrict. You can say, okay, in order to study cancer deaths, I'm only going to look at people in between 15 and 44 years, depending on your research question. You can also stratify based upon groups. So you can say, you know what, I'm going to have my Alaska population here, my Florida population here. I'm going to stratify based upon geographic location and just examine that way. Also, you can do multivariable statistical analyses. We'll talk briefly about this, where you actually adjust for confounding in regression equations as an example. But today we're going to talk about one method, and that's standardization, okay? So you can either directly standardize in order to get age-adjusted rates, or you can indirectly standardize and calculate a standardized mortality ratio. So direct adjustment. So now we're going to focus on what's the difference between direct adjustment and indirect adjustment. So direct adjustment yields age-adjusted rates. So when comparing two complete populations over time, or comparing two populations in different locations, the basic idea is the same. You create a new combined population and you apply from there. If you wanted to compare looking at population of Augusta compared to the population of Atlanta, that would be another comparison that we could make. Direct method may be used if age-specific death rates in a population to be standardized are known and suitable, and the standard population is available. So let's look at an example. The annual crude mortality rate for a county is 96 per 100,000 in an early time period and 126 per 100,000 in a late time period. What is known about the age distribution in the two populations at different times? And what are the effects on the crude rates? So looking here at the direct adjustments, let's say we want to make a direct comparison and we want to do direct standardization from an early time period to a late time period. So ultimately what you would do here is you would calculate the death rates for each of the categories. So for example, in order to get the death rate per 100,000, you would be given the 60 deaths over the 500,000, right? And so then from there you could set up your proportions similar to what I showed you with the age-specific death rate, okay, because that's what the 12 per 100,000 is. And you get your age-specific death rates for both the early time period and the late time period. From there, what you do is you combine the early time period and the late time period population groups in order to get a standard population. So let me show you an example. So for the 30 to 49 year old age group, you see that the number is 800,000. Well, if you go back here, the way that that was calculated is you take 500,000 from the 30 to 49 in the early time period and combine it with the 300,000 in 30 to 49 from the late time period. And so basically what you're doing is you're trying to find a common denominator in a standard population. So then you apply the death rates that you calculated earlier to that standard population, and ultimately what you end up getting is the expected number of deaths using the early rates and then an expected number of deaths using the late rate. Okay, and so you do that for every single age group, and ultimately, you know, the way that you calculate the expected number of deaths is you take the standard population, so 1 times 2, which is the death rate that you calculated on the last slide, and that yields 3, the expected number of deaths. So then ultimately what you do is you add them all up, and so you get an age-adjusted rate using that standard population, okay? And so here you can see if the research question is more deaths occurring at the later time period than the early time period, well, you say, okay, well, there's a different age structure. So here you can see that the age-adjusted death rate in the early time period is 124.3, but actually in the late time period it's only 101. And ultimately what that tells you is no, actually the death rate has decreased once you remove the effects of age. And that's really important because if you were to look at crude rates, it may seem like more people are dying, but in reality it's there's older people, there's a more percentage of population that are in the older age group, so it's not that more people are dying. So that's why it's really important that you look at age-adjusted rates. So let's say, for example, that you don't have reliable age-specific death rates available for you. Now this can happen. Let's say, for example, you're studying rural populations and that kind of data is not gathered, or in smaller populations every one death is full of impact, so ultimately they're unstable. Maybe only one person dies, you know, a month, and then if you have 3 people that die the following month, because so few deaths occur, the 3, you know, looks catastrophic when in reality maybe it's not. So if they're unknown or they're unstable, meaning the age-specific death rates in the study population, then ultimately what's going to happen is you need to use the indirect standardization method. Now again, when you see the word standardized mortality ratio, know that you're doing indirect standardization. Okay, so this is used to compare observed number of deaths to the expected number of deaths. Okay, and so observed number of deaths in your population under study, and it would be the expected number based upon if that population followed in line with a standard population. So here's a calculation for standardized mortality ratio, observed over expected times 100. So the number of observed deaths due to heart disease is 600 in a certain county, so let's say the population's small. But how many would we expect, assuming that it conformed to United States standards? Well, here in this case, we would expect 1,000 perhaps, and so 6 over 1,000, even though 600 deaths in a certain county may be very impactful when compared to, let's say, a standard population such as the U.S. population. It's actually only 60% or 0.6 of what's expected. So let's look at an example. In a population of over 500,000 Caucasian male minors, there were 436 deaths from tuberculosis in 1950. So let's say that you have a research question that says, is the number of Caucasian minors who die from tuberculosis higher than people in the general population who die from tuberculosis? Well, we're going to do an indirect standardization method because the population of Caucasian minors may be very small and the rates may be unstable. So ultimately what we do is we have our estimated numbers of Caucasian minors in each age group, okay? And then we get the death rate for tuberculosis from the general population. So you can see there's that slight difference. Instead of getting the rate from our study population, like in direct standardization, we're getting our rate from the general or the standard population, okay? And so you apply 1 times 2, so you take the estimated population numbers per age group, times it by the death rate from the standard population, and ultimately what you do is you get the expected number of deaths if your study population, Caucasian minors, conform to the general population numbers. And so that gives you your expected numbers, you add them all up, and then you say, okay, well, what did we actually observe? So that would be given to you, okay? And so you can see, for example, we expect only 9 deaths if the minors were to be compared to the general population. We would only expect 9 deaths to occur in the 20 to 24 age group. However, we observed 10. Is that good? Is that bad? Looking down 25 to 29, we only expect 13 deaths if the Caucasian minors population conforms to the standard population, but we actually got 20. So ultimately what you need to do now is to calculate the standardized mortality ratio, which is observed over expected. And so what that would end up doing is saying, okay, well, it's 436 over 181 times 100. And so that would ultimately yield 241, or sometimes it's not even multiplied by 100, so it's just 2.41. And what that does is that tells you whether what you observed is in excess of what you expected or what you observed is less than what you expected. So if the observed and the expected numbers are the same, obviously the SMR would be 1.0, or in this case close to 100, okay, indicating that what you observe is very similar to what you expect. There's nothing unusual. However, if you were to calculate an SMR of 2, what that means is the death rate that you observed in your population. So, for example, a population of Caucasian minors, that's 2 times greater than what you expected, okay? So going back and looking at this example, remember our research question is, do Caucasian minors die at higher rates due to tuberculosis than compared to the general population. And based upon this SMR, you see that Caucasian minors are twice as likely to die based upon tuberculosis, due to tuberculosis, than people in the general population. And so from an occupational health standpoint, that's a really, really important thing to investigate once you calculate it. So that's an example of indirect standardization. So we talked about cause-specific rates, we talked about crude rates, we talked about adjusted rates. There are a lot of terms in epidemiology, and so I hope that this special session helps to solidify those terms and help to really tease out the nuances between them. Thank you.